So, good afternoon from India, and I'm Dr. Praveen Chandra from New Delhi, Medanta Medicity Hospital, and my colleague Dr. Abhinav, who is here with this in this case, and my other team members who are ready to help in this complex case.
So our patient is a 57-year-old gentleman. He presented with a effort angina from last 1 month, which was revealed on TMT as well, stress test, which showed a wall motion abnormality while the peak stress. So although the patient is also having a comorbidity of chronic liver disease, for he already on treatment by a gastroenterologist, although his platelet functions and platelet counts are less. So after due clearance from the gastro and the hemat team, so we are proceeding for his angiography. So angiography was done, which showed a critical, moderate stenosis of the LAD, proximal to mid. Mostly it is calcified and it is 80 to 90%. So our plan was to just fix it with cutting balloon and IVL followed by a drug-eluting balloon because his platelets are low. So we don't want to keep him on the dual antiplatelets.
So we have done this first angio shoot. You can see that the calcification is there, and this artery is a long lesion. So this is a challenging situation. Next, please. And the second challenge, as he already said, that the antiplatelet therapy will be an issue, especially in the long run or maybe even the midterm. So our strategy here is to first prepare this lesion vessel very well. And what we have done is we have taken a first wire in the LED, and there is a small wire again also you see in the diagonal which is gone there, but eventually we will put that into the LED because it is a FFR wire. I will tell you the importance of why we are doing this, because finally we want to end this procedure with a cutting balloon and a shock wave, and then followed by a drug-eluting balloon. If the FFR is good, if the lesion is well opened up, and it's like almost like a stent-like result, we won't put a stent here. Okay. So here you can see in the epicranial tight lesion, heavy calcification. We are trying to put this wire, which is not, we went with difficulty into the diagonal, but into the LED we could put a BMW, and this is the dilatation with a 2mm balloon. After this, we did IVUS. You can show the IVUS image, please. So IVUS only crossed till the midpoint because it is so heavily calcified. You can see that the
Catheter was stuck at that.
catheter was stuck at this place, and then we are pulling it back. And as we pull it back, more and more calcium, almost 360 degrees, and the entire artery is full with calcific plates and nodules. Okay, so I have taken this is the 3mm shock wave. Try to pass this distal tightest portion because that is, yes, we have crossed it. Okay, fantastic. So we have crossed this position of the tightest where even the IVUS catheter was not crossing. So I will do a balloon dilatation with this shock wave. Go up to 1, 2, 3, 4. So we have started the pulses. You can see that the balloon is expanding. Slowly deflate. So 10 pulses given. Second set of pulses again at the same point. Yeah, so it is expanding well. Go up. 1, 2, 3, 4. Yeah, go up. Ariocaudal deflate. So the patient is having angina. I think we can give him some rest in between. Check, please, whether the flow is happening or not. Yeah, the flow is happening, so we are not in a problem now. Okay, go up. 1, 2, 3, 4. 40
Negative.
pulses given. Deflate. Let him breathe a little bit. Pressures are okay?
Yeah, STT changes are there.
No, I don't see. Give some saline, please. He was ischemic, so the pressures went down, but now it is recovering, as you can see. I'll give him some rest. The pressures are now back to 120, 130. Okay, so we'll go do one more cycle. Go to epicranial. Pressures are okay now. All fine. No ECG changes. Okay. So this is the most toughest point here. You can see go up. 1, 2, 3, 4. We have given about 70 pulses. Some more I want to give. I want to cross this. Yeah, we have
Yes.
crossed it. We will give some more. 1, 2.
Negative.
Deflate. So that's nice. I think it's quite looking quite nice. Deflate. 10 more.
10. One cycle. Yes.
Yeah, so give one more. 10 more. 1, 2, 3, 4. This is the last set of pulses, and the balloon is fully dilated. So there doesn't seem to be any residual here. अभी खत्म हो जाएगा. So the
NTG.
pain will go away. Give some nitroglycerin, and now we will check with the IVUS.
It is going easily now.
So now the IVUS has crossed easily, and we'll do the IVUS. So this is the distal vessel is looking almost like 3, and yeah, so you can see that the disruption of the calcific, these plates, and also at this point is fracture in the calcium, and this is looking quite okay. So you can review the IVUS now.
Play.
Yeah.
Distillate is around 2.6 maximally.
Okay, let's take a shot. You can see nitro given.
Yes.
That looks nice. Okay. So we will take a 3 millimeter balloon.
Cutting.
Yes.
3 cutting.
So for further dilatation, 315. You know why we are doing this? Because our aim is to not put a stent. And one of the issues with this patient will be antiplatelet therapy.
310. Open.
Go to the iliocranial. You can see that this balloon is moving quite smoothly now. Okay. Epicranial. Okay, go up. 1, 2, 3, 4, 5, 6, 7, 8. Let the saline be continued.
Yes.
And check, please. Check. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. So we are doing, quite a reasonable amount of dilatation. We are not shying away with pressures. We are going up to 12 atmospheres, and you'll see how it goes. Deflate. Okay, check, please. Check a little bit. Okay. Yeah. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Okay. So this is serial dilatation using this cutting balloon, Wolverine. Deflate. Let's take a shot. Looks okay. Okay. Epicranial. To me, it looks quite good. And
340.
340. We have a 340
Deb.
DEB. And what is the size of this vessel? Should we go to 3.5 or not?
Distillate was around 2.7.
3. It was 3. Yeah, it was 3. Distally, it was 3. And so since we don't see any major dissection, which we will see in other views as well, iliocaudal, please. Iliocaudal. And you can see, so the strategy in these patients who are very, very high bleeding risk, we can take a stent which has, indication for a high bleeding risk. But many times, if you are able to finish it, if there is no huge dissection, then in this view, there is appearing to be some dissection. Shall we do a OCT?
OCT. OCT.
So in the meantime, we are taking this 3.5 into 30. No, 35 will be better. 35.
35. 35. 2.753.
35. RO quadrant. Show me the RO quadrant view. The branches are all fine. Everything seems to be okay. Go back. In this view also, it looks okay.
No major dissection.
I mean, there is some, dissection, but not that much. It's not, impairing the lumen at any place. Iliocranial. I think, we are at a position where we can start thinking of
Depth.
just a DEB.
Yes.
Okay. But in the proximal part, we might have to do some more dilatations where just before that first diagonal. How much is the size of the vessel in the proximal part?
Live करना एक मिनट. Live.
I'll do another IVS run. Make sure that we have a good lumen. And then the lady has a plate on the 6 o'clock to 9 o'clock position, but the lumen is good. Nothing to be done. This lumen is good. Again, it's okay. There's some, here we see some
Hematoma type of.
hematoma or something like that. Although the lumen is okay. Yeah, the lumen looks quite. You see the plates have been broken. Show me the MLA. So we'll keep looking at these MLAs. Show the
4.8, more or less 5.
5 square. So I'll do one more dilatation. Give me the balloon. And at this point also where there was maximum calcium, it's about 3.84. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. We go to high pressures here also. Check please, where are we? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Deflate. This is a Wolverine 310, okay? Go up 2, 4, 6, 8, 9, 10, 12, 14. Deflate. It's fine. Okay, go up 2, 4, 6, 8, 10, 12, 14. Okay. Deflate. So this heavily calcified lesion has been now treated completely. The with the 3 into 12 IVL shockwave, and then using a Wolverine 310. Okay, so now we are planning to take a drug-eluting balloon, and we will take a 30 millimeters. Yeah, so give me a 30 millimeters. Magic touch.
2.7.
So we are taking a 30 millimeter eluting balloon. Ready? Okay. Going very easily. Not a problem. Okay, check please. Okay, go up. 1, 2, 3, 4, 5. 30 millimeters balloon. And we have taken a slightly higher size, but we are going at low pressures. Okay. So pressures. Yeah, and we will do it for at least 1 minute. Patient will have some pain or dilatation using a magic touch sirolimus eluting balloon, 30 millimeters in length. Okay. And you can see that the dilatation of the balloon is complete. There is no residual anywhere, which means that the lesion has been fully treated. Okay. It's 1 minute now, and we will continue for another 30 seconds if he tolerates. Just 30 seconds. Bas. 30 seconds or 15 seconds. He is having some chest discomfort, which is now natural, but typically this is 1 minute, 30 seconds. Deflate. So we are deflating it now because he can't tolerate anymore. Otherwise, I could have gone even a little bit. Looks nice.
There is some haziness in the proximal part.
We will see. RO quadrant. So we are keeping the stent thing provisional. There is some dissection though, but it is not really flow limiting. Iliocranial, RO cranial.
NTG.
It appears that we are almost done, and No major flaps anywhere, and the flow is very good. We can even check the FFR if you want. Should we?
No.
Okay. The wire is not functioning well, so we have to get a new one. I don't think that's really required. So we can just stop here.
Yes.
Yeah. So we are almost done, and I'm just going to take a shot. It's very nice. Get almost a stent-like result, and the residual seems to be very less. There is nothing, no haziness, and there is no.
Major
And the area
flaps.
was above 4.5
4.8.
to 5 square millimeters everywhere. 5 square millimeters.
More or less a hematoma type of thing. More.
Yeah, I think that will heal. Okay, so we are done. So thank you very much for being with us. And this is what we wanted to show you, this strategy of stentless angioplasty, where you just do good amount of angioplasty of the vessel